Welcome to the third webinar episode in our series of webinars in collaboration with our partners ISCoS. I'm your guest host, Raymond Hovens, currently Benelux Marketing Product Specialist for both Flowfreak and Equina products, and I'm honored to be your host today. Today, we will be discussing a holistic approach to urinary and bowel continence care. And before we begin, let me welcome our guests, Mrs. Margo Kauwenberg and Debbie Queen, spinal cord injury nurse specialist from the Southeast region for the Spinal Injury Association. Welcome to you both.
Thank you.
I'm really looking forward to today's discussions. I've met with Mrs. Kauwenberg more than 10 years ago in my capacity as a marketing product specialist, and you are here today to tell your story from working as a continence nurse to obtaining a Cauda Equina syndrome, a spinal cord injury, incomplete. We have many questions for you to ask, but before we go, Margo, I would like to invite you to tell your story.
Okay. My story is that I was working as a continence nurse, and in 2014 I got back pain and I had a surgery, and after that surgery I had a bleeding, and so I got a Cauda Equina syndrome and incomplete spinal injury, and that makes me a whole other role I got from a nurse. The role was getting for a patient, and I think it's interesting for other people to hear what it means when you get that diagnosis.
Yeah, thank you. Margo prepared a PowerPoint presentation which will be run now.
Good afternoon. My name is Margo Kauwenberg, and I've been asked to come and tell what it means when you change from a continence nurse to patient expert in Cauda Equina syndrome. What are the consequences for me as well, medical, physical and social, after a surgery that went different than expected? What does it mean if you suddenly become a patient in your own field? Do you actually speak of a patient? And is it nice to be a continence nurse or not? The reason I'm here today is that after a surgery to my back in 2015, a laminectomy was done, and as a result of that I got a Cauda Equina syndrome. My aim is that I hope that talking about what I experienced, there will be more knowledge about the consequence of this, which certainly also apply to our profession. Everybody knows them, dates that will never disappear out of your head. A well-known example is 9/11. For me, these dates are the 8th and 15th of June 2015. After the surgery on June the 8th, I had a bladder retention for which I received an indwelling catheter, which was removed after 3 days, and I was able to pee with great difficulty. The flow was very weak and I was peeing drop by drop. Sometimes one micturition lasted for 10 minutes. I had a post-voided residual ranging from 50 to 450 milliliters, and I was incontinence at unexpected moments. I also felt no urge. The stool was obstipated and not spontaneous. I got Movicol, Dulcolax and Microlax for this. I had a huge pain in my leg when moving, standing and walking, for scale 8-9. When walking I go through my right hip and had almost no strength in my right leg. I was also able to walk with great difficulty, using a walker with 4-arm scale. After 8 days, an MRI was made, and it turned out that there was a bleeding in a spinal cord, which required emergency surgery. After this operation, I could not pee for weeks again, and a dwelling catheter was placed. After 3 days, the catheter was removed, and again I had a very weak flow and a residual that varied. I felt no urge and went to the toilet clockwise. Defecation was still not spontaneous and walking was very difficult. The pain in my neck was considerably reduced but still had nerve pain. My right foot dragged and I needed crutches to walk. I also had a deaf feeling in my legs and Cauda region. The day after, a neurologist visited me and told me that I was diagnosed with Kauwenberg-Middeljans syndrome. The symptoms of the Cauda are what is written here. My bladder problems remained and my post-void residual varied, for which I was advised by the urologist to perform self-cathetization 3 times a day. This advice was in accordance with the guideline. After 2 weeks I went home instead of the planned 5 days. The pharmacy came by in the clinic and handed over medication and catheters for the first days. And then you are just at home and you got hematuria. A nurse just had catheterized with a Miltiman catheter. I decided to drink a lot, but feel very insecure. I had a surgery in the Maartens clinic where Joke works. She is a nurse practitioner and I know her from education and workshops. I sent her an email after the weekend with a lot of questions. At first she helped me with good advices by email and get an appointment with her and a rehabilitation physician. I knew the way, but how are things going with all those people who don't know? On the forum of the spinal cord patient organization, I read a lot of stories of people who absolutely did not have follow-up care or even did not get a diagnosis. It would be helpful if there was from the beginning somebody who could be contacted. It would be great if the treating physician had said after his diagnosis, you know this is a bad message, but you can still pop over to rehabilitation physician and a nurse practitioner for further assistance. The nurse practitioner guided me with my bladder and bowel problems. I have many problems with my stool. We had regular mail contact and she explained to me why I have these complaints and what I could do about them. At a certain moment she advised to think about anal irrigation. What did I think a lot of that one patient? Years ago, she came to me on a continence consultation hour because she got the advice to start with transanal irrigation. Now I am the one who is getting this advice. Now I don't want to go start just as that patient. I feel ashamed and the step to start with bowel anatomy is a way too big. I think a lot about all those emotional conversations I had with this woman. Now I know how it feels. What a difference. I got all the time and space I needed. The nurse practitioner let me decide and did not push. My bowel problems are getting worse, and when I arrive at work and have to clean there up, it is the last straw that breaks the camel's back. I started transanal irrigation. At the rehabilitation center I got clear explanations and practiced the first irrigation. I feel very uncomfortable and insecure. This was all according to the guideline. Once at home, I think I can do it alone. After all, I have learned to so many people transanal irrigation, but it don't work that simple. Again, I have to think about a patient. She came in walking and told me she had a Cauda Equina lesion. She came for incontinence equipment advice. With the knowledge of today, I have seriously failed. How will I manage transanal irrigation on holiday? I really don't like it. In the end, I arranged a campsite with private sanitary facilities. Ideal, but I still feel uncomfortable because I'm afraid others can hear me. I prefer transanal irrigation every other day. Because my neurogenic bladder, I have regularly urinary tract infections, which is much reduced by the intake of probiotics with cranberry. I catheterize 2-3 times daily, and for the pain I received a neurostimulator which gives at least 50% pain reduction, and I could reduce part of my pain medication. Sexuality has changed, but can handle this well with my husband. All this has a huge physical and social impact. I do not work anymore and due to my limited mobility. Contact with others has been reduced. I go to the urologist and rehabilitation doctor once a year. In case of problems, I can always contact the rehabilitation center. I'm worried about the future, especially regarding my bladder and bowel. The care standard describes faster deterioration in muscle strength by age in partially innervated muscles in people with Cauda Equina syndrome than in people without Cauda. As a result of aging, walking, bladder and bowel function is more likely to deteriorate. But I still get a lot of happiness out of my family, my children and grandchildren and hobbies. I also still photograph what I really like to do. I thank you all for logging in and listening to my story.
Margo, thanks for your story. Even though I know your story, it still has an impact on me. But thanks again for sharing your story. I have some questions for you regarding your presentation and me knowing you are a continence or you were a continence nurse.
Yep.
So you might think it has been a given because of your background as a continence nurse. Can you tell me what is your biggest struggle when it comes to IC and transanal irrigation?
Well, my biggest struggle was to start with the colonic irrigation, and I was really dreading this and somehow ashamed of this.
Mm-hmm.
I didn't want to, and I resisted this too. And it made me very emotional. Catheterisation was not so an issue, but colonic irrigation was.
Mm-hmm. Okay. And when you got the grips of intermittent catheterization and transanal irrigation, how did you maintain motivation to continue with this bladder and bowel management? Which tip or tricks or mindset helped you with this?
Well, I mainly got my motivation from the fact that I noticed that the use of catheters and bowel irrigation gave me more freedom. If it protected me from an unaccepted loss, oh, I'm sorry. And I also felt better physically. It took a long time for me to accept it emotionally. I have to put my mail out. Sorry. Yes. Maybe we have to do this question again because my mail pop up.
I don't know, but I think until you told us that your mail popped up, I think it was okay.
Okay.
Do you think, Heather?
In terms of editing, it'd be easier if you did the question again. Thank you.
Yeah. No.
Okay. How did I do it?
My motivation.
Yeah, I have to try to go back to the last question, or the first question actually. Margo, when you got the TAI transanal irrigation and intermittent catheterization under your belt, as we say in the Netherlands, how did you motivate yourself to continue with the bladder and bowel management? Which tip or tricks or mindset did help you with this?
Yeah, well, I mainly got my motivation from the fact that I noticed that the use of catheters and bowel irrigation gave me more freedom. It protected me from unaccepted loss, and also I felt better physically. It took a long time for me to accept it emotionally. That is so. Yeah.
The hard part.
Yeah.
Imagine. Yeah. What do you think the knowledge needed for patients with bladder and bowel problems is needed?
Well, in addition to what every patient should know, I think it's important that they know what is a Cauda equina lesion and what is an incomplete spinal cord injury and what are the possible consequences of this. Where can you go for this? There are special rehabilitation centers and patient associations with a lot of information and forum. So I think that is very important. I personally have a lot of forum for Cauda Equina syndrome patients. You can go there with your questions and get a lot of recognition and tips. And so I also give tips that I know a thing or two about.
Yeah.
Yeah.
So maybe that's an early start for my next question, because what do you think? Which information does the patient need before they start with intermittent catheterization and transanal irrigation?
I think it's important that the patient know how does a bladder or bowel function under normal circumstances and what has changed in this due to the spinal cord injury. And the importance of self-catheterization, colonic irrigation, the interplay between bladder and bowel, I think is very important.
Yeah.
And the different aids out there and decide together with the patient, I think is that important. And when I learned colonic irrigation, the nurse practitioner came up with a different brand than the one I want. I had the knowledge and could therefore declare it. I think it's important to explain clearly what is there and what's the pros and cons are. Sometimes an advantage according to the patient outweighs a disadvantage according to the healthcare provider. But I think also tips on how to deal with it outdoors, at work, on vacation, etc. And that important is that the patient know when do I contact and with who.
Yeah, clear. Thank you very much. Margo, and now I think it's time to invite Debbie as well into the conversation. And Debbie has a long-standing career in spinal cord nursing and has worked as a senior nurse at the National Spinal Cord Injury Center at Stoke Mandeville Hospital for 25 years. I understand you have been developing the nursing service of the Spinal Injuries Association for the past 6 years with your colleague.
That's correct.
And now we'll have a number, maybe you have some questions for Margo as well.
Yes, yeah, I'd just like to ask Margo a few more practical questions, I think. Margo, as a continence nurse, when you worked as a continence nurse, did you used to ask patients to keep a diary of their bladder and bowel activity? And when you, and now you're in this situation, did you realize you would have to do that yourself? And how was that?
Indeed, I have asked patients with bladder bowel problems to keep a diary. And of course, I understood the importance of doing this, but I never realized that I would one day become a patient myself. To measure is to know, as we have learned, and I found it difficult to do this outdoors. At home, you use a liter size and you write it down immediately. But also it makes me insecure because I saw that my residue was variated, and I had advice to catheterize 3 times a day, but sometimes I thought, is this enough or is it too much? So I can imagine patients calling immediately if they notice that the residue is different than in the hospital, and that is the consequence of to use a diary, because you see what is the residue.
Yes, thanks. And so when you taught patients how to perform intermittent self-catheterization when you were working as a continence nurse, you may have thought you were teaching quite a simple procedure to those patients, quite a simple technique. When you had to pass catheters yourself, was it that simple?
Well, it's certainly not that simple. Yes, the act itself is easy to learn, but putting it into practice was not so easy. Catheterization takes longer than peeing. It's given for me an uncomfortable feeling if somewhere was crowded and people were waiting to go to the toilet, for example, in a theater. Sometimes it just didn't work then. And realize that, I think, when the patient leaves the house, it only starts for him or her. She will be dependent on resources anytime, anywhere for the coming weeks, months, years, until that. And it's only an action that you learn. It has consequence for your daily schedule, vacation, etc., whole life. And it also creates uncertainty. It raises questions about how things will go when you get older. Also consider this.
Yes, it involves a lot of planning, I'm sure, every day when you go out, of course. Do you, with your experience as continence nurse, do you now think about things for yourself that might go wrong or problems that might occur?
Yeah, absolutely. Remember the time I came home after being catheterized by a nurse with a Teman male catheter, and I had a hematuria. It makes me very insecure, and I also worry about the long-term effects. I do have a urinary tract infection a few times a year, and what if I stopped responding to antibiotics? Does the bowel irrigation have no adverse effect on my bowels? In the past year, I had abdominal pain and diverticula came out after examination. And then I asked to myself, is this due to rinsing, or is it normal? As you can see, I also have many questions, and I'm not even talking about what I will be like when I get older. What if I become 80, 90 years old? Can I still flush and catheterize myself? Or will I be dependent on home care? And wouldn't an indwelling catheter be given too easily with all the associated problems because it's easier for them? I'm worried about.
Lots to think about, Margo. Yes, yeah.
Yeah.
You've mentioned that you started using transanal irrigation, but how long did you experience bowel incontinence before you made the decision to use transanal irrigation, and how easy was it to make that decision?
It took about 4 months before I started colonic irrigation, and it was the hardest decision ever. Everything in me resisted it. It made me very sad and angry, and I found it's very drastic on my life. It also reminded me of a patient, what I said in my presentation, who I supervised to start flushing. She sat in front of me crying and didn't want to flush. And now I was the one who didn't want to. And I now felt exactly how she must have felt. I ran into a colleague at work to whom I told that I might have to do a colonic irrigation. And she responded that she would not find this anyone at all. And I thought by myself, you really don't understand.
Yes, absolutely. Yeah. So you mentioned a continence nurse that you liaised with and spoke with who helped you. Was that somebody that you knew? Was it a colleague or somebody you knew? And how did that feel, knowing that it was a colleague, a work colleague, perhaps?
It was, I could be the nurse of conventions and training, and we didn't work in the same hospital, but it felt like familiar to guided by someone who was already known. I had no problems with it. I trusted her vast knowledge.
Excellent. Good, thank you.
Yeah, thank you, Debbie and Margo, for this more practical side of things. And I just wrote something down that turning a technique, which is quite simple, if I may I'd say it like this, to turn it into practice, that's not that easy. There's a lot of questions arising, and patients are taking this into their daily lives. And I think, or maybe we can go on this issue later, how nurses can interact with patients more on this side of the story. So less technique, but more how to cope with transanal irrigation and intermittent catheterization. Actually, now we go into the topic of the webinar, the holistic approach. So as we continued, it would be great to hear some of the thoughts of both Margo and Debbie as we continue to discuss the issue of management and knowledge, as well as a holistic approach to the intermittent catheterization and transanal irrigation. So please, Debbie, in your experience, what's the most difficult when dealing with this type of invisible problems? Or maybe no, sorry, Margo, this will be your question.
Yeah.
In your experience, what is the most difficult part when dealing with this type of the types of invisible problems?
Well, that is an issue because we walk and people think there is no problem anymore.
Mhm.
And the trouble with an incomplete spinal cord injury is that the problems are not always visible on the outside. I think of neuropathic pain, bladder and bowel problems, sexual changes, and it's not visible. And for many people, it doesn't exist.
Mhm.
It's also not a fun topic to talk about at parties. So now I have to say that over the years, I have become easier at this. For example, if you go away for a weekend with the photo club, I'll just say I need a room with my own toilet because I intestinal flushing, and it feels good now.
Coming back to your working days, how did you instruct or manage your patients in your active role as a continence nurse? And what would you have done differently on hindsight?
When the patient come to me office, I had 1 hour for explanation and instruction. And for colonic irrigation, I had the first hour for explanation, and then an appointment of 1.5 hours for instruction. And the follow-up was done by telephone as needed. Patient also received an information leaflet with the telephone number where I or my colleagues were available and when they should definitely contact them. And the changes I made afterwards were not so much in the structural approach, but more that I was better able to what it felt like to start with self-catheterisation or colonic irrigation. I realized more that this has a great impact lifelong.
And how do you value the experience you had as a continence nurse while you obtained the injury yourself? Meaning, what were the benefits or drawbacks of having this knowledge?
Yeah, I really felt like I had fallen into a bad dream. I soon felt that the urination was not going well and to look long and did not empty properly. This was not always understood in a nursing ward on the orthopedic department. I was even told to focus a little less on it and I just try again when I had over 1/2 liter residue and just repeat a little dripping for 10 minutes. But then they answer, it's coming okay and be easy. And the bizarre thing is that I didn't say anything when I was catheterized by a nurse with a male Thiemann catheter. I didn't want to be a nuisance, but I did make me bleeding. I got hematuria of this. I didn't get the full explanation and the instruction I would have liked. It feels different when you have to apply it yourself. It was quickly said to, as a continence nurse. But I was also very insecure and had a lot of questions. The advantage was that I was aware of the different types of catheters and bowel irrigation, so that I did have an active role on this.
Okay, and now back to the holistic approach. I think Debbie will also join us now. We tend to refer to patients in a general way, in a way that the patient is a label. And a label is one, but no one is the same. Same as that a spinal cord lesion or a Cauda Equina syndrome is the same for all patients. But how should a continence nurse approach a person with urinary and bowel issues due to these injuries?
Well, I think it's important that a continence nurse know what a Cauda Equina syndrome or incomplete spinal cord injury is. And know that even if someone enters on foot, there can still be a lot of damage in items of, in terms of bladder, intestines, and sexuality. Many continence nurses in hospitals do not see many patients with this condition. Most are treated in a rehabilitation center. But there are also many patients who have never been to a rehabilitation center or who no longer receive a checkup, but who do have a deterioration in their complaints. So be alert of this. Know your guidelines, know which guidelines there are and provide clear instructions on paper or digitally for the patients. And every patient with a Cauda Equina syndrome or incomplete spinal cord injury is different. Nobody is the same. The complaints are therefore not the same, and make sure you know which complaint can occur or at which level of lesion. And be clear in what the possibilities are. Take the time to build a relationship of trust. And also indicate in the beginning that recovery can occur and that this can take a long time. Sometimes it will be years. And make sure you are easy to contact. I have Joke. Joke has been a great help to me, and she responded quickly for emails and gave me extensive answers to my questions, but not everyone has such a Joke. And many patients are not even seen by a rehabilitation doctor and have to find out for themselves at home. And sometimes you have patients referred by the urologic and during your consultation to learn self-catheterisation, but then also discuss how the stools and sexuality are going, because there are most of times there are more problems. And sometimes it takes a number of consultations before the patient is ready for what you want. And take time, if possible, or see if there is an interim solution. If someone don't want to start now, look what you can do now, and then maybe start later. Proceed step by step. Too much information no longer arrives. And do you realize that the use of catheters in colon irrigation can be psychologically very drastic? Ask on a patient, where are you afraid of? What makes you insecure? Can I help you with that? I think that that's the most important things are.
And Debbie, if I may ask, what's your take on this? How should the nurse approach a person with this type of problem?
Well, I have to agree with much of what Margo has just said, because she's covered a lot of ground there, and it's about treating everybody as an individual, because even if people come to you with the same type of problem, such as Cauda-Equina syndrome, they won't have exactly the same symptoms. They won't manage it in the same way. Emotionally, they will deal with it in a different way. And to be honest, some people have very limited knowledge even about their anatomy and about what exactly has happened to cause this problem. Some people don't even realize it's because of the damage to the nerves that this is why they have this problem. So obviously there's quite a lot of education involved, educating the patient about their condition and about what's available to them. But according to, it's the same as what Margo is saying, I think it's the whole emotional aspect is very, very difficult. And it's very difficult when you're doing a telephone consultation with somebody, as I do frequently with people with Cauda-Equina, and they cry frequently because they're so upset about what's happened, and they're going through the grieving process. They're grieving for what they've lost. They're grieving for the loss of continence and mobility and sexual function and sensation. And that's a very difficult thing to deal with. And it's very difficult sometimes to give that right support over the telephone. So ideally, you'd like to have that consultation on a face-to-face basis. But some people are even very reluctant to explain these issues to you, or they might just say to you, well, I can't wee properly. They don't tell you about the other problems, and so you do have to then start asking, well, what about the bowels? How are the bowels working? What about your sexual function? How's that working? And quite often the sexual function is something people won't volunteer initially. They will talk about not being able to wee. That's more acceptable than not being able to open their bowels, or to talk about their sexual function, which is much more intimate for the person.
Yeah, sure. Yeah.
Recognize it, but it's maybe talk easier about the problems with the bladder, but the problems with the bowel are very drastic.
Yes, it's not something we go around talking about every day.
Yeah. No,
not the most easy. No.
about going to the toilet.
Yeah.
Okay, going to our final discussion and take-home messages. Margo, if I may ask, what makes, you touched upon it in the PowerPoint, but what makes your life worth living? What has the incomplete spinal cord injury or the Cauda equine syndrome changed your life, both socially, emotionally, and with work?
Yeah, unfortunately, I lost my work. This was very bad, but I have now given it a place. I noticed that everything cost me a lot of energy. And for example, one evening visit, I have to recover for 2 days. And I also found it very difficult to find my way, for example, how to go on vacation and how I could still carry out of my hobbies. We like to walk, and that took time to find out now how this was possible with my wheelchair. And it's not so easy. Focus. I think you have to focus on what is possible and not on what is not longer possible. And you can do that if you have to give the change a place. And I enjoy the little things. For me, it's, for example, babysitting, the grandchildren, photographing. But this does take time. Accepting that you are dependent on catheters, colonic irrigation, and all that huge of may use your wheelchair, etc. It takes time. And but it's looking for a way to deal with this best, and don't let this hinder you.
Yeah. Thank you very much. And Debbie, from our discussion today and hearing Margo's story, will this impact your teaching on providing care as you do nowadays?
Yes, of course, because I think, although I was aware of all the complexities of the person with Cauda equina syndrome, I think Margo's explained just how the emotional impact is massive for people. But on top of that, the whole managing the situation in terms of your daily life, for things for Margo that were really important, like going on holiday, still being able to go to work, the impact of her condition on her daily life, and how tiring it was for her. And I think when I now have consultations with people with Cauda equina syndrome, I think that will always be forefront in my mind, as to it's very well to talk to them about doing intermittent catheters, keep a diary, do intermittent catheters, try transanal irrigation. It's very easy to talk about those things. But I think in terms of the emotional impact, I'm going to have that in the forefront of my mind when I'm talking to people. Yeah.
Great. Thank you, Debbie. Thank you, Margo, for now. And if I'm wrapping up this webinar, then from my point of view, not one incomplete spinal cord injury or Cauda equina syndrome is the same. Symptoms which should be recognized by the nurse might be called the same, but the way the nurse and the patient is dealing with it differs a lot. Talking about the emotions coming with it, or turning the technique into your daily life. And maybe the role of the nurse could or should be the one to help the patient to understand what's going on, be there for any one question from the patient when it concerns incontinence, and if possible, coach the patient to refine her or himself. Not only with personal health, with proper medical devices chosen by shared decision making. I think Margo talked about this a bit shortly, but I think she touched upon this important topic. But also guide the patients, if needed, to colleagues for the social or the work or intimacy related questions, because I personally think not all nurses have all the tools or should not or are not able to have all the tools to work with all those non-specific urology issues. So I think it's paramount of a nurse to be aware and teach her or himself in the developments within the field. And maybe this webinar has touched upon some specific themes in this regard. So I would thank both Margo and Debbie for being there, and to all people watching, thank you for watching, and goodbye. It has been a wonderful discussion, and as part of the Wellspect partnership with ISCoS, we have a number of podcasts and webinars already published that you can listen to and view. So please do remember to subscribe to the ISCoS YouTube channel for alerts of new content going live. Thank you all again for watching, and we hope you found our webinar informative.